Wow, thank you very much for coming tonight. What an amazing turnout, and what an incredible crowd. We thought we'd try a couple different types of talks today, and my talk's going to be more of an orthopedic talk, and at first, about shoulders. And as Sean said, 75% of people are going to have orthopedic surgery in their life. Chances are it's a knee or a shoulder. I'm with Northwest, and I specialize in knees and shoulders. And specifically, I want to talk about the rotator cuff today. And I'll touch on a couple other little things so that we don't leave anything out. But the rotator cuff disease is by far the most common condition to affect the shoulder. And rotator cuff disease starts with impingement syndrome and tendinitis, and it goes to rotator cuff tears. We'll also talk for a few moments about instability and then also about arthritis. This is an x-ray of a patient, and when we look at that x-ray, and every time we see somebody with a shoulder or joint injury, we take an x-ray. As an orthopedist, I can tell that patient, that unlucky patient, has a rotator cuff tear. And you can see it because there's sclerosis in the tuberosity. Is it working for you like that? So there's sclerosis in the tuberosity of the humerus, and there's wear to the acromion right there. So we know that patient has a rotator cuff tear. We get an MRI scan to see how unlucky they are, and on an MRI scan, that's the rotator cuff. And that's the end of it, and it's supposed to be attached down there. So that patient is very unlucky. They have a big rotator cuff tear. And the biggest advance in shoulder surgery by far in the last 30 years has been arthroscopic surgery. And if you think about it, in 1980, no one wanted to be a shoulder surgeon. And the reason was you had to guess what was wrong, make a big incision, and try to fix what you thought was wrong, and then see if it worked. And in 1980, 1/3 of your patients would get a good result. You had to go to therapy as an orthopedic surgeon to be a shoulder surgeon. What changed was the arthroscope, and in the mid-80s, we started doing arthroscopy. At first, we used it to look in the shoulder and figure out what was wrong. And then we made incisions and fixed what we could fix. And then we learned how to start fixing things, first taking out bone spurs and then repairing things. And what's really been beautiful about the arthroscope is that the shoulder is protected by muscles. There's no easy way to get in, and there's no way to get in without doing a bunch of damage. So when we learned how to fix things from the inside with the scope, we learned how to solve many shoulder conditions with incredible results. So these are pictures of that rotator cuff tear. And you can see the top left picture is a tendon with a hole in it. It's not attached to the bone. And then the next thing that we do is arthroscopically, we put in little anchors. And those are those sutures that you see in the top right. And we pass them through the tendon and then pull them down to bone. So we figured out how to sew the rotator cuff down to bone using an arthroscope. That's just another picture of what it looks like when we do this surgery. And what we found is overwhelming, just crazy good results with doing this surgery this way. When you used to hope you'd make someone better, now we want to make people perfect. We make shoulders normal, and the results are so much better than the old open days. Literally, healing results are better, pain results are better. But the one thing that doesn't get better is time. It still takes a long time to recover after a rotator cuff repair. And if you go back to that first patient, that guy with the rotator cuff tear on the MRI scan, the x-ray, it's that guy. So that was 1 year ago. And I can say what I hear patients say all the time about their shoulder, and that's, my shoulder feels better than it's felt in 20 years. And that's the coolest thing in the world to see as a doctor. So future studies, so we get great results, but there's so many things that are still wrong. And the biggest thing that I hear is, man, I love my shoulder, but I hated what I had to go through, and I don't want to do that again. And that's by far the biggest thing we heal. And the problem is, the rotator cuff takes literally a year to heal the bone. And what we would love to be able to figure out how to do is to get that tendon to heal the bone quicker. And there's a lot of things we could study. One of them is platelet-rich plasma, which is just a spun-down blood derivative. Another one is maybe stem cells will be the answer for rotator cuff healing time. And then there's a lot of interest in things like human growth hormone, parathyroid hormones, testosterone. You know, there's a number of studies that we could do. There's a number of questions that we can still answer in trying to get shoulders to heal more quickly. And then there's the pain management side, and you know, that's something we, every day, every patient nowadays, we have to talk about pain management because it's such a big problem in our country. And you'll hear about cold RFA. There's a medication that we can give people called tranexamic acid, and it stops bleeding. And we haven't proven that it helps in the shoulder, but if you have less bleeding after surgery, you have less swelling. And theoretically, at least, we could then get you better quicker with less pain. Nowadays, there's long-acting numbing medicines. There's a medicine called Exparel that is like Novocaine, but it lasts for 3 days. And if we can figure out the appropriate way to use that with this type of surgery, maybe we can really cut down the acute pain. And then 25 years ago, there were studies done that showed that anti-inflammatories, NSAIDs, slowed down bone and tendon healing. And they were done in rabbits and goats, but they were never really pursued in humans. So for the last 25 years, we've been afraid to tell people to take the anti-inflammatories, which are very effective pain control medications. So we really need to really look at that and see if maybe it's safe to give anti-inflammatories, because it would make such a difference for our patients. The other things that'd be interesting to study are like genetic testing. You know, nowadays you can map out everything genetically. If we could predict ahead of time which patients were going to get stiff, which patients would re-tear their tendons, which patients would, you know, have issues, then again we can answer a lot of these questions. And the final thing that I just want to talk about is rehab. So when you tear your rotator cuff and we fix it, you're looking at 6 weeks in a sling doing nothing. 6 weeks with an arm you can barely feed yourself after that. And literally then 3 months of really protecting your shoulder so the rotator cuff gets through the early phases of healing. And if we can, we would really love to see rehab change. We'd love to be able to speed that up, you know, with all the other things we talked about, and with looking at our rehab techniques and seeing what the physical therapist can do for us. There's a couple other things I want to talk about. So people, there's a concept of an irreparable tear, a tear that's too big to fix. I bet there's people in the room that have told they have a tear that's too big to fix, just live with it. Well, we have a technique now that's been incredibly successful for those patients, and it's called a superior capsular reconstruction. And essentially what we do is use a graft, and the graft is a graft that we buy constructed. It's called human dermal allograft, and we replace the rotator cuff. And it's amazing how well these patients do, especially when the indication, most people without a rotator cuff can't lift their arm, and afterwards they can. So I thought I'd just touch a little bit on instability. It's hard to run through, you know, advances in shoulder surgery in a scenario like this, but shoulder dislocations, like I think we saw an x-ray of a shoulder dislocation. We heard about the second and the third one. Well, nowadays, if you dislocate your shoulder, we don't tell you to go home and do it again. If you're going to dislocate it again, we fix it after the first dislocation. And the reason we do that is every time you dislocate your shoulder, you lose bone. And if you lose enough bone, then we have to do another level of surgery. Then we have to do a bone transplant surgery. So the focus on instability has really changed. I just wanted to throw in a slide of what a bone graft surgery looks like. This is called a Latarjet reconstruction. And it's the best surgery that we have for people with recurrent instability in bone loss. So then what about arthritis? And arthritis is really tough in the shoulder. And there's a trend towards using smaller implants, but there's a bigger trend towards avoiding arthritis. And if you look at patients that have shoulder arthritis, the causes are recurrent dislocation. So if we can fix that, we can take care of that whole group. It's failed prior surgeries. The surgeries that people used to do, open surgeries, caused stiffness that led to arthritis. So we're hoping we have less arthritis to deal with in the future because we're just not that good at it. This is an x-ray of arthritis, and I just thought it'd be interesting for people to be able to see what it looks like. So this is an x-ray of the shoulder, and the joint's gone. there should be a big space between those two bones, and there's none. So what we have available to us is that. It's a total shoulder replacement. And we replace the ball and the stem and the socket. And it's a great pain relief surgery, but it doesn't have the function that we would like because they wear out and they fail. So what about patients that have arthritis and no rotator cuff? That you can't do a shoulder replacement if you don't have a rotator cuff. So we do a reverse shoulder replacement. And essentially, we turn the ball around and put it on the socket and make a stem out of the humerus. And this, again, is a good surgery for pain, but it's not a great surgery for function. So, as I said, in conclusion, arthroscopy has really changed shoulder surgery. It's dramatic how much better surgery is today as a result of arthroscopy. The results are so much better, but we still have a lot to learn. So there's another topic I'm supposed to talk about, stem cells. Everybody want to stand up and move around a little bit? Is it too tiring to sit there this long? It would be for me. I'd run around the room. So the reason I picked stem cells as another topic to talk about is literally 50% of my patients come in and say, well, what about stem cells? Because everybody's heard about stem cells, and there's so much misinformation, and there's so much confusion in this whole stem cell business, and there's so much trickery in it too. It's the weirdest field. It's the weirdest thing I've ever seen in medicine. One of the quotes, the more we learn, the less we know, the more we think we know. Fits stem cells perfectly. As a result of stem cells, there's a whole new field in medicine. It's called regenerative medicine. It didn't exist 10 years ago, and everybody talks about regenerative medicine today. Probably going to be the biggest growing field in orthopedic or in medicine. But you have to understand, what is a stem cell? And by definition, a stem cell is a cell that can self-replicate, so it can reproduce and make itself again, and can turn into different tissues. And every type of stem cell has different abilities and different possibilities. The other things that we've learned about stem cells is that they can fight cell death and they reduce inflammation. And this reducing inflammation is a really fascinating thing. Stem cells, there's something in inflammation called metalloproteases. And stem cells can affect the metabolism in metalloproteases. The other thing about stem cells, everybody thinks they're brand new. Stem cells have been around for years. They were first described in 1950. Embryonic stem cells are the most powerful by far. So embryonic stem cells are the stem cells. But the problem with embryonic stem cells is there's ethical issues. And in 2005, President Bush signed a law that said that embryonic stem cells are off limits. So they can't be used in the United States unless there's specific allowances. And embryonic stem cells are from in vitro sterilization. So you take an egg, you sterilize it, and then when it has 100 cells, you harvest those cells. So it's not a fetus yet, but it's going to be. And then those cells can be cultured, and you can grow cell lines from those cells that then can be used for numerous types of research. So the types of cells, the embryonic stem cells are the powerful ones, they're the ones you don't have. The common ones are called adult stem cells, and everything in your body has stem cells. So we can get them out of bone marrow, and in orthopedics we use those frequently. Those are called BMAC, bone marrow aspirate concentrate. And then there's stem cells that come from fat, and they are pluripotential. They can become many other kinds of cells as well, but they like to become fat. And then there's stem cells in your blood. And then there's two other types of adult cells, and it's confusing to people, but fetal cord blood is something that you can buy after a baby is born, that stem cell companies sell. And fetal cord blood has stem cells. They also sell amniotic fluid, and it's interesting, there's an article this month in the Journal of Sports Medicine where they took this amniotic fluid from all the sources they could get it from, and they couldn't find any stem cells in it at all. So probably amniotic fluid is not that great an idea. But finding that and even reading that today tells you about some of the problems that we'll get to with stem cells. So what can you do with them? What are the uses for stem cells? And the potential uses are amazing. Maybe we can inject them into damaged tissue. Maybe if you break your leg, we can inject it into your fracture. Or if you tear a muscle, we can inject it into the muscle. Or maybe we can inject them into a joint and grow new cartilage. Or why not just do tissue engineering? We could, when you tear your ACL, instead of putting a hamstring tendon in for your ACL and waiting for it to become an ACL, we could grow your ACL. 6 weeks later, just put in a brand new ACL. And in the future, most of the tissue engineering people think that they'll be able to grow hearts and lungs and kidneys and solve the transplant issues that we deal with today. But the only treatment that's really FDA approved and readily available is bone marrow transplant. And everyone knows somebody that's had a bone marrow transplant. It's a common procedure for blood dyscrasias. So when I was doing my research for this talk, I was trying to find out what the potential uses are for stem cells, and I found the answer is everything. So especially the stem cell people will tell you there's nothing that you can't cure with stem cells. But the stem cell world has exploded in the last couple of years. And the whole concept is the most amazing concept in the world. They have these undifferentiated cells that will do anything for you. So, and we all get on the internet, and everything we read on the internet must be true. But what you have to really understand are the players in the stem cell world, because stem cells, it's the hardest thing for me to describe. But first of all, when you go online and you hit stem cells, the first 100 things that you'll see are advertisements. And they don't look like advertisements. They look like research papers, and they look like they look like science, but they're not. They're advertisements by companies that make money selling stem cells. And you have to know the players in this business. So one player, stem cell companies. 4 years ago, I went to one of those company meetings, and those companies sell you these meetings, and you can sign up. You can be a nurse, a doctor, a chiropractor, anything you want to be. And the meeting that I went to, you paid $1,500. And you went to the meeting, and I thought I was going to learn all this science about how stem cells work. And there was no science at all in the meeting. They taught people that had never touched a knee before how to put a needle in a knee and do an injection. And then they taught us about the finances. And the two things that I took away from that meeting, leaving in disgust, of course, were they said that you should charge at least 10 times the amount that you paid for the cells. So if you paid $500 for fetal cord blood, you should charge $5,000 to inject those cells into someone's knee. And the second thing they said, and it's kind of interesting because Sean is a businessman that knows how to think in people's heads. They said, in America, if people pay more for it, they'll believe it works. So the more you charge, the more they'll believe it works. And that's part of the reason that if you look at the price range, it's unbelievable. I tried to call up stem cell clinics to find out what the range was. It was $1,500 to about $12,000 for an injection in the knee. The average is probably in the 3 to 5 range. And it's hard to find out because they want your social security number and they want you to come talk to them, but you can do that. So there are the companies out there, and you know about them. And then there's the clinics. So you can set up a stem cell clinic, and you can set up multiple stem cell clinics and do advertisements and get people in and inject stem cells. Nobody controls you, nobody regulates you, you just do it. And then there's providers. There's doctors. There's doctors that do the research and talk to their patients and do stem cells as part of their practice. And then there's major medical institutions. And the major medical institutions are the ones that really do the research, that are doing the big studies. Right now in America, there's over 1,000 clinical studies going on about stem cells. But none of them are the hillbilly injections where you inject stem cells in your butt and it supposedly cures whatever. You know, none of them are like that at all. All these research projects are research projects that makes your eyes sore to read the titles, because we're all talking about chondrogenic potential of S4 cells. You know, so there is a lot of real research going on in the stem cell business. especially at major institutions. Mayo is doing a big study on stem cells and arthritis, and so is Stanford. One of my friends is one of the researchers at Stanford, and they get between 200 and 250 calls a day of people that want to sign up for the study. So that's how big the interest is in stem cells. It's incredible. This is Consumer Reports 2019, The Trouble with Stem Cell Therapy. You can read it. The art, you know, and what I would recommend to people is that if you're interested in stem cells, you've got to look past the advertisements from companies. Look at this, look at Consumer Reports and see what they say. There is no place that I know of that's even remotely close to medicine that has as much dishonest advertising. This is an advertisement that I took off one of the biggest stem cell companies in America. And it shows a normal x-ray on, or it shows an x-ray on the left of severe arthritis with bone changes and bone deformity, and the x-ray on the right of a normal knee after stem cell injections. And everyone who is a scientist knows that this is absolutely impossible. And these kind of ads are getting yanked all the time, but there's nobody really watching the hen house, and that's the problem. There's an article in the Spokesman Review about the stem cell clinic here in Coeur d'Alene. That's a picture. I would urge you to get online and read the article because it's a fascinating thing to learn about. I took one quote from that article, and it's from Dr. Charles Murray. And Dr. Murray has more publications than you can print out about stem cell research, and he's the director of regenerative medicine and stem cell research at UW. And that was his quote. Anybody that asks you to pay for stem cell therapy right now is a charlatan. So I said nobody's watching the hen house, and that's starting to change. In Washington, if you inject stem cells, you have to put up signs in the clinic that says that you're doing something that's kind of weird. In South Dakota, you get in trouble for doing it. In New York, the Attorney General just shut down a stem cell clinic in New York City for making false claims, for saying that they could fix things they couldn't fix. And you guys can read that, I don't have to, but there's nothing in that list that they can't fix. So, tin cup or holy grail. If I inject cortisone into a Medicare patient's knee, the reimbursement is $72. Compare that to what we talked about in the cost of stem cells. They're really unproven doing the shotgun technique where you just inject some kind of stem cells. They're really profitable and they're unregulated. I looked up dangers on the internet, and that was an interesting topic to look up. So there was a stem cell clinic that injected people in their eyes for macular degeneration, and several of their patients were blinded permanently. There's a guy that had spinal stenosis and injected stem cells out a fatty tumor and was paralyzed permanently from his fatty tumor. There are multiple reports of teratomas, and teratomas are when you inject stem cells and they turn into a kind of tumor that has multiple different cell types. There's infections and there's deaths. But why do we do them? And part of the reason we do them, and I have to admit I've done them, is because people want them. So when I've done them, I've done BMAP, bone marrow aspirate. So this is my confession. Bless me, Father. I've done bone marrow aspirate because it's right there and it's easy to do. And people have heard, well, that'll help my rotator cuff to heal. So we draw some bone marrow out of the bone we're working on and spin it down and inject it into rotator cuff repairs. When I've done it for the cost of the equipment. You know, so, and I think there's a big difference between charging 10 times the cost it told you to do it versus doing it for someone that wants it and believes in it. Because as physicians, we just want you to be happy. The truth of the matter is, the bottom line, when all is said and done, we want people to be happy with what they got. And we want people to be heard. You know, when you come in to talk to your doctor, and your doctor says, and you say, hey, I want stem cells, and your doctor says, I'm not having anything to do with it, your doctor didn't listen to you. You know, so that's why we do them. So, semi-conclusion. Stem cells have tremendous potential. Research is ongoing, and every year we're going to know more and more about what works and what doesn't. But stem cells of everything in medicine in America need regulation. The FDA has said, well, you're not allowed to use embryonic stem cells or highly cultured manipulated cells. Other than that, we don't want to be involved. And the FDA says, we don't have the resources to fight these stem cell clinics. On the internet, I pulled up a map of California, and the number of stem cell clinics in California is staggering. There's not a town without 2 or 3. And in regenerative medicine, we really need to have a board of regenerative medicine. In orthopedics, we have a board. We have to take tests. We have to do the right thing. If one of us does something that is wrong, our board could come after us and take away our certification and our license. So regenerative medicine needs that kind of regulation. But so the other thing about stem cells is they're kind of like religion. You're allowed to have beliefs. And I believe that stem cells have anti-inflammatory potential. If you inject them in knees, people feel better because there's an anti-inflammatory effect. They probably help with healing of tissues. They may be able to help us heal damaged cartilage. And in orthopedics, if you can figure out a way to avoid arthritis and not have to do hip replacements and knee replacements and shoulder replacements, not put metal in a joint, make it a normal joint again, then that's amazing. And if you look at the research, and it's interesting, I pull up 100 studies in the last 4 years on stem cells, and what they're all working on isn't do you inject them or not, it's how to make the stem cells do what you want them to do. It's how to program stem cells, so that's where the research needs to be done. But I think that stem cells will be the biggest advancement in medical treatment and medical research of our lifetimes. And when we look back at stem cells, they'll be bigger than penicillin and polio vaccine and everything else because there's so much potential with them.